of functional hypogonadotrophic hypogonadism is the female athlete triad. And finally, women with anorexia nervosa can also present with both features of HA and also belong in the female athlete triad. Whilst both PCOS and FHA have distinct pathophysiologies and the diagnoses are supported by guidelines, in practice, differentiating the two is quite challenging, especially because they are both diagnoses of exclusion, and so they must be qualified by a prerequisite to exclude other causes of menstrual disturbance. So there are multiple guidelines for the diagnosis of PCOS. The most recent one being the international update published in 2018 by Helena Tide and colleagues. And according to which, PCOS is diagnosed in the presence of two of hyperandrogenism, either clinical or biochemical, a polycystic ovarian morphology on imaging with an increase in the cutoff of follicular number per ovary from 12 to 20, or the presence of oligoanovulation. Now, the Endocrine Society recommends the following criteria for the diagnosis of FHA: a menstrual cycle length persistently more than 45 days, or amenorrhea for more than 3 months, in the context of either a history of weight loss, vigorous exercise, or stress, and the presence of hypogonadotrophic hypoestrogenism with a recommended estradiol cutoff of 50 picograms per ml, which translates to 183 picomole per liter, which is actually not very low. They also recommend doing an MRI scan of the pituitary gland to exclude any other pathology, and advise that a progesterone challenge test could be offered. And I'll present some data on this last point later on in the talk.
Now, Maria, do you know, is 50 in their unit, is that their detection limit?
So 50 picograms per ml is actually 184, which would be detectable, I think, with our assay.
Yeah, because well, our detection limit is 100. So we report less than 100, but we don't report any numbers. Does that make sense? So if their lab detection limit is 50, then they might just say 50 because that's as low as they can go. Does that, you know what I mean? I
see. Yes, whereas our assay seems to be more sensitive than that.
Well, they've gone for a round number, 50. We've gone for 100, but ours are 100 picomoles. You know what I mean? I think that might
be
50.
Might be the reason why. Yeah, that's true. Yeah, and then we'll go through some studies looking at some different cutoffs and how they are used to predict whether someone will have a progesterone response to a progesterone challenge test. Now moving on to.
Yeah, she can. Yes, hang on a sec. Go on. You shout.
So your progesterone challenge test is just 10 milligrams of medroxyprogesterone for 10 days. Is that right?
I think there are different guidelines. So here we use 10 milligrams of medroxyprogesterone for 7 days, and then would expect a bleed a week after the last tablet was taken.
Okay, thank you.
And moving on to a diagnosis of anorexia nervosa. The most up-to-date criteria are set out in DSM-5, and anorexia is diagnosed in the presence of restricted energy that leads to a low body weight, disturbed self-body image, intense fear of weight gain, or a lack of recognition of the seriousness of the low body weight. Hypogonadotrophic hypogonadism is no longer part of DSM-5, but we know that amenorrhea can be present in up to 89% of women with anorexia nervosa. And once again, a BMI threshold is no longer defined in the criteria, but for a woman to be qualified as having moderate or severe anorexia nervosa, they need to have a BMI of less than 17. And moving on to the female athlete triad, this is comprised of the presence of menstrual disturbance and negative energy balance and low bone mineral density. So the prevalence of secondary amenorrhea in athletes can be as high as 69%. And with regards to the bone mineral density, the cutoff for that that we use is a Z-score of less than -1. Now, many features of these two conditions are found in both conditions, are found and are shared. For example, the presence of PCO morphology or increased antral follicle count on imaging, which is a cardinal sign of PCOS. And indeed, it's seen in up to 88% of women with PCOS, has also been observed in around 30 to 45% of women with FHA and up to 30% of amenorrheic women. That is, in their case, it's an incidental finding. So to demonstrate that point, I'll very briefly take you through the case of one of our participants. So she's a 21-year-old university student studying here at Imperial with a past medical history of ADHD. She had menarche at the age of 13 with a normal pubertal milestones, and she had regular periods until the age of 16 when she started the combined oral contraceptive for contraception. She came off that at the age of 18 and has been amenorrheic since then. She also has a positive family history of PCOS, with 2 of her sisters having it, and they have an ovulation and clinical hyperandrogenism. She doesn't report having any acne or any hirsutism and doesn't report any dramatic changes in her weight. She says she's following a healthy plant-based diet. She walks everywhere and is generally active, but doesn't go to the gym. She also said that she's had progesterone challenge tests and she usually has a bleed after those. On examination, she had a BMI of 19.6, no acne, no hirsutism, and a Ferriman Galway score of 4. With regards to her blood, she had an LH of 2.1, an FSH of 3.6, with an undetectable estradiol and progesterone. Her testosterone was normal, it was not 1.6, and she had a raised AMH at 59.1, and she had normal adrenal androgens. Her ultrasound scan showed endometrial thickness of 2.7 millimeters and polycystic ovarian morphology found bilaterally with an antral follicle count above 20 on both ovaries, but with ovarian volumes of less than 10 mils. So what is her diagnosis? So she currently fulfills criteria for both PCOS and FHA. And perhaps a more pertinent question to ask ourselves would be, what is the cause of her amenorrhea currently? Because that would determine the way we manage her in clinic. So now I'll quickly go through a few parameters that we've looked at in our review. So starting off with menstrual disturbance, which can be subdivided into oligomenorrhea and amenorrhea. But even defining these symptoms can be quite confusing. For example, when we view them in terms of menstrual cycle length, this varies from 35 days to 38 days in the case of oligomenorrhea, whilst amenorrhea varies from 45 days to 90 days. Now, due to cycle variability, oligomenorrhea can also be defined as having 4 to 9 cycles per year, whereas women with amenorrhea have 3 or less cycles per year. Women with PCOS will most commonly present with oligomenorrhea, whereas FHA is usually associated with amenorrhea. But we also know that up to 40% of women with PCOS can become amenorrheic. In terms of onset of menarche, women with FHA tend to go through this pubertal development later on than their peers, especially if their body fat percentage is low. In young girls with PCOS, the onset of puberty very much depends on their BMI. If their BMI is high, menarche is observed early. If the BMI is low, we observe late menarche. Moving on to BMI, we all know that PCOS is more common and FHA is less common with increasing BMI. Women with PCOS are almost twice as likely to be overweight and 3 times as likely to be obese than healthy ovulating controls. And a BMI threshold of 26.6 discriminated 300 Chinese women with PCOS from 100 women who had regular periods, with an area under the rho curve of 0.78 and a sensitivity of 55% and a specificity of 98%. On the other hand, FHA can be due to low body weight, so it's commonly associated with low BMI. But even in patients with FHA that's related to stress, their mean BMI is on the low side. We also know that adaptation to an energy deficit balance can maintain body weight at the expense of energy-consuming functions such as reproduction. And we see this in women with anorexia nervosa, where the BMI can be normal at the time of first amenorrhea in up to 38% of women. And we also see this in female athletes, where up to 30% of them are anovulatory despite having a normal BMI. We also know that the set point for body weight at which menses are lost varies between different individuals, and it's now recognized that recovery of menses may require approximately 2 kilograms more than this specific set point and can take up to 2 years after the regaining of normal body weight. So when assessing patients, it's important to note not only their current BMI, but also how much weight they've lost and what their weight was when their menses first stopped. So in summary, FHA is uncommon in overweight women, whereas both PCOS and FHA can happen in women with low or normal BMIs. Women with FHA have reduced bone mineral density for their chronological age due to hypoestrogen. I think the slides got a bit confused. Sorry. So body composition is also affected differentially. So body fat percentage is higher even in lean PCOS compared to weight-matched controls, whereas fat distribution and their fat distribution is typically android. Whereas in FHA, we see that we have a lower body mass than BMI matched controls. And we know that up to 30% of body fat will be required for the menses to be resumed. And the fat distribution in these patients is typically gynoid. Moving on to bone mineral density, women with FHA have reduced bone mineral density compared to their chronological age, which is mainly due to hyperestrogenism, their nutritional deficits that they might have, or other endocrine abnormalities, such as having a high cortisol. And that's why the FHA guidelines recommend arranging a DEXA scan in all women who have had amenorrhea for more than 6 months. And a Z-score of less than -1 rather than -2 is deemed sufficient to indicate low bone mineral density in women who have female athlete triad features, because exercise can increase bone mineral density by 5 to 30%. With regards to the bone mineral density of women with PCOS, this very much depends on their BMI. And there seems to be some differential kind of regulation at a BMI of around 27. So a meta-analysis of bone mineral density in women with PCOS found no differences in density in women with a BMI of more than 27, but we can see that in women with BMIs less than 27, their lumbar density is marginally reduced with a pooled mean difference of minus 0.07. Moving on to the genetic predisposition to these two conditions, we know that PCOS is genetically predisposed with 70% heritability in monozygotic twins and 38% in dizygotic twins or sisters. A GWAS meta-analysis identified 14 polymorphisms that are associated with PCOS, including in genes implicated in insulin regulation, obesity, and ovarian function. And moving on to FHA, a study found that 7 out of 55 women with FHA had heterozygous variants in genes that encode Gnrh, nerve function, or migration, which are the genes that are also implicated in the phenotype of CHH. So women with FHA can be genetically predisposed to menstrual disturbance after having an environmental stimulus such as losing weight. And there's also a high degree of heritability in eating disorders. For example, anorexia nervosa can be seen up to 60% in twin studies. And usually the genes implicated are ones that regulate metabolism. So with regards to Gnrh pulsatility, we all know that Gnrh pulsatility is reduced in FHA, and this favors FSH secretion. So LH pulse frequency, which is a surrogate of Gnrh pulse frequency, is reduced in long distance runners with secondary amenorrhea compared to controls. And LH pulse amplitude is reduced in women with FHA. We also know that pulsatility is disrupted at energy availability of less than 30 kilocalories per kilogram. And although reduced reduced LH pulsatility is considered a hallmark of this condition. There was a study reporting that only 8% of the 49 women that they studied were completely apulsatile. And healthy women will have reduced LH pulsatility during their sleep, but studies have shown that LH pulsatility overnight is increased in up to 45% of women with HA. Women with PCOS have increased Gnrh pulsatility that favors LH secretion. They have an inherent abnormality in the Gnrh pulse generator that is independent of sex steroids. They have higher pulse frequency than control, and LH pulse amplitude is also higher, and specifically in lean PCOS, more than obese PCOS or healthy controls. So overall, LH pulse frequency is increased in women with PCOS by around 40% and reduced in up to 80% of women with FHA. And it seems that pulse frequency might have a greater discriminatory potential compared to pulse amplitude. So with regards to how women respond to a Gnrh challenge test. So in FHA, we have seen that LH responses very much correlate with a baseline LH, and that LH responses in FHA are very similar to those of controls. With PCOS, we see that the LH rises are 2 to 3 times higher than in controls. But once again, the LH responses correlate with baseline LH. We also found that LH responses are negatively correlated with the patient's BMIs. So perhaps even though the responses in women with PCOS are higher, this is because they start from a higher LH, and therefore the percentage change is not different between PCOS and controls. And a study reported that an LH to FSH ratio of more than 2.1 30 minutes after a Gnrh test had a sensitivity of almost 88% and a specificity of 88%. And as we all know, in women with FHA, we see lower LH, but FSH levels that are not different, which reflects this predominant FSH production with a lower Gnrh pulsatility. And looking at women with PCOS, 40 to 60% of women have LH values that belong up in the higher 95th centiles. And interestingly, LHs are more commonly raised if they are associated with menstrual disturbance. And the study reported that the LH to FSH ratio of more than 1.3 had an area under the rho curve of 0.87 in identifying women with PCOS. So moving on to AMH levels. AMH is produced by the granulosa cells of growing antral follicles in the ovary, and therefore its levels correlate with antral follicular count. AMH is also increased in PCOS, and we found that it corresponds to the number of PCOS features, and in fact better predicts menstrual disturbance than antral follicular count. And the meta-analysis identified that an AMH threshold of 33.6 picomoles per liter had a sensitivity of 80% and a specificity of 83% for the diagnosis of PCOS. In FHA, it's increasingly more recognized that AMH levels are moderately increased compared to healthy controls. So the graph here shows a study where women were categorized according to the WHO anovulation categories. In WHO 1, we see mainly women with HA, whereas in WHO 2, we see women with PCOS. So we see that even the WHO1 category has more raised AMH levels compared to controls, but not as much as the WHO2 category. And indeed, when we did the numbers in this paper, we found that up to 69% of women with PCOS had a raised AMH of 65 picomoles per liter, versus 7% of women with FHA that had a mean AMH of 24.3. Now, looking at ovarian morphology. So PCOM is the cardinal feature of PCOS. And morphologically, PCOM ovaries have this central stroma surrounded by peripherally located follicles. compared to a multicystic ovarian morphology, which is characterized by increased number of small ovarian follicles without this peripheral distribution. And I'm sorry, the graph on the right should actually say multicystic ovarian morphology. However, because this classification very much depends on the reporter, they have come up with a different way of assessing this, and we use the term follicular number per ovary. So instead of focusing on the distribution of the follicles, we mainly focus on their number. So women who might have multicystic ovaries because they have FHA, they might be classified as having PCOM just based on the number of follicles that they have on ultrasound. Moving on Inhibin B. Inhibin B is produced by the granulosa cells of the ovary, and their levels peak during the follicular phase of the cycle. And we also know that Inhibin B levels are negatively correlated with BMI in both PCOS women, but also in healthy women. Now, the data with regards to Inhibin B levels are quite inconclusive. So a study from back in 1998 found higher levels in women with PCOS than in controls, whereas a few years later, PIGME found that there were no significant differences between the two groups. Inhibin B levels are also lower in women with FHA. Now, FHA is a low estradiol state, whereas an estradiol is supposed to be preserved in PCOS. So generally, because estradiol assays perform poorly at low levels, we have sought to find alternative methods to assess those, such as examining for cervical mucus or using a progesterone withdrawal test. So accordingly, women with PCOS are expected to have a withdrawal bleed after a short course of progesterone, whereas women with FHA are not. And originally, estradiol was reported to be higher in women with HA who had a withdrawal bleed, and some papers suggested a threshold of 147 picomoles per liter that predicts whether someone would bleed or not. But more recent studies have found that 60% of women with HA have a withdrawal bleed, and that this response does not correlate to a specific estradiol level. And in fact, endometrial thickness better predicts the response to progesterone withdrawal than estradiol levels. 93% of amenorrheic women with an endometrial thickness of more than 1.5 millimeters will have a withdrawal bleed, compared to only 6% of those with a thinner endometrial thickness. And endometrial thickness is generally higher in PCOS than controls, both in early and late follicular phase. So it's unclear what a progesterone withdrawal test provides, other than some information about estimation, information about the estradiol levels, which you can actually assess by either a more sensitive estradiol assay or by doing a scan and assessing the patient's endometrial thickness. Moving on to insulin resistance. Women, yeah, sure.
So just going back to the progesterone, because I've always struggled with this, because it's in PCOS they bleed, and in about 60% of FHA they bleed, correct? So what is the utility of this test? Why would it be useful? It isn't. Okay.
Exactly. I think so. The papers that we found that initially suggested a threshold for estradiol were written in the 1970s and 80s. So when the estradiol assays were very poorly performing, and therefore I think the premise was that if there was enough estradiol to have sufficient endometrial thickness, giving progesterone would cause those women to bleed. So it was a kind of a roundabout way of seeing how estrogenized their uterus was. But indeed, we're now finding that women with FHA can bleed, irrespective of what their estradiol levels are. So I think a better predictor is the endometrial thickness and this cutoff of 1.5.
Yeah.
I'm not sure whether. Sorry, could you repeat that question?
What about measuring a serum estradiol? I mean, it's changing every day, isn't it? You have to several.
Isn't a big endometrial because they have had more exposure to estradiol under the curve over time?
I think
Exactly.
as the
So I
Can you hear that? Did you hear that, Maria?
Yes, exactly. So for example, if we take a woman who has FHA and is completely amenorrheic, so that she's stuck in the follicular phase and there's no, she's not cycling, she would be hypoestrogenized, and therefore she would have a very thin endometrium, compared to a woman who has PCOS who's oligomenorrheic, and therefore she does cycle, albeit more slowly, and therefore we would expect her to have a higher estradiol level and a thicker endometrium.
Yeah, thank you.
So I'm not sure whether do you use progesterone withdrawal tests clinically to decide if someone has PCOS or FHA? Is it something that is readily in use?
The gynecologists do.
But it's not really helpful. I mean, on an individual level, you just can't. You don't know whether they're in the
gynecologists definitely do. The gynecologists give them a present challenge and then document the outcome.
Maria, can you hear me? I don't know. Can anyone hear me?
Yes, yeah, I can hear you, Alexia.
I wonder if 60% of women with FHA having a withdrawal bleed is quite a high number. And I do wonder whether there was some misdiagnosis in those studies where they actually also had PCOS in those patients as well. Because I think certainly in my limited clinical practice, and I'm also here with Dr. Cox, it's quite a high number, 60% to fail a progesterone challenge in HA.
Yes, I think you're raising a very valid point, and it's something that we have considered throughout working on this review, that each study had very different criteria about who qualified as FHA and who qualified as PCOS. And indeed, some of the inclusion or exclusion criteria almost predisposed them to, it was a self-fulfilling prophecy, and then they would respond in a specific way because they use some specific criteria.
Exactly. I mean, in clinical practice, I don't do the progesterone challenge. I just do the endometrial thickness. I think it's the purest way. And so
you do an ultrasound?
I do, yeah, do an ultrasound, transvaginal ultrasound, and endometrial thickness. You know, of up to a couple of 2 to 3 millimeters, anything less than that, probably okay. And you don't need to do the progesterone challenge, because if it's negative, you don't really know where you are sometimes. If it's positive, it's helpful. But if it's negative, it can be difficult. Sometimes they don't take it properly, then you give them a different dose of it, you give it for longer, as Amir was, you know, there's lots of different protocols and things like that.
Yeah.
So we were very surprised when we saw that it's recommended in the guidelines, even though when we went through the whole guideline, we couldn't find any evidence backing that up. So I wonder whether they included it as part of an assessment of a woman who's amenorrheic, especially if they have primary amenorrhea, to see whether there's any outflow obstruction problems. But then you would expect, you know, the FHA guideline says that they shouldn't have bleeding if they are truly amenorrheic and having FHA. So I'm not sure how useful that test is. So moving on to insulin resistance. So women with PCOS have a 3 to 5-fold increased risk of impaired glucose tolerance depending on their ethnicity. And insulin resistance is more common in women with PCOS, whether they are overweight or lean, than compared to overweight controls. And both glucose, basal insulin, and stimulated insulin levels are higher in PCOS than in weight and age matched controls after having an oral glucose tolerance test. So in lean PCOS, the fasting plasma glucose did not significantly differ between controls and the patient group under investigation, but the 2-hour glucose after an oral glucose tolerance test and the HOMA-IR were increased. In contrast to all of those, in FHA, we see hypoinsulinemia and hypoglycemia. And basal insulin is lower in FHA than in controls, and insulin sensitivity following an oral glucose tolerance test is also not affected. So it seems that it could be used as a quite useful parameter to discriminate between the two conditions. Now, insulin inhibits hepatic SHBG synthesis, so that hyperinsulinemia is associated with reduced SHBG levels. And also we know that SHBG levels are inversely correlated with the BMI, both in healthy women and in women with PCOS. But still, even after correcting for BMI, we find that SHBG levels can be lower in women with PCOS, whereas women with FHA didn't have any difference in their SHBG levels compared to controls. So overall, it might be that using a free androgen index, so that takes into consideration the SHBG, might be a better differentiator than using the unadjusted testosterone levels alone. And moving on to androgens, we know that in PCOS, insulin resistance is tissue specific. So whilst there's a resistance to the effects of insulin to reduce the glucose, the ovarian fecal cells are actually sensitive to the effects of insulin, and there's increased androgen production that can contribute to the hyperandrogenism. So women with PCOS have increased median testosterone, DHEAS, androstenedione, and free androgen index. And also we find that, interestingly, women with lean PCOS tend to have higher adrenal androgens, whereas women with obese PCOS have higher testosterone and FAI. Women with anorexia nervosa have reduced testosterone levels and SHBG levels and DHEAS that are not differentially regulated compared to controls, but they also have a low alpha reductase activity. And some papers recommended that perhaps in the future we might have a DHEA challenge test. So this is because we know that 5-alpha reductase activity is differentially regulated. So it's reduced in FHA and increased in PCOS. And therefore, in a paper looking at giving dexamethasone for 4 days and then giving DHEA overnight, resulted in increased DHT and increased testosterone in women with PCOS. Mind you, that paper was from 2003. So this kind of, yeah, it doesn't seem to have become more prominent. It doesn't seem to have become standard practice.
Yeah, I mean,
it's an interesting thought.
That those patients were PCO. I mean, this is the problem. Your primary definition.
So in all of these studies, they say X is up in PCOS, Y is low in FHA, but we don't know how to define the grey area. So how did you know in the first instance whether it was PCOS?
Yes. Indeed. So in our review, we tried in the tables we formed, we tried to actually note the inclusion and exclusion criteria for each patient cohort, for each reference, because, as you say, different studies use different cutoffs. And also we have some papers from a few years ago when the assays were performing very differently. And also, for example, the Rotterdam criteria were used for this paper in 2003, whereas our criteria now are very different. Moving on to leptin levels, we know that these correlate with fat mass and therefore can be expected to be increased in PCOS and reduced in FHA. But also fasting leptin levels can be correlated with estradiol levels. And also this could also contribute to the difference in leptin levels that we see between FHA and PCOS. So a meta-analysis found that leptin was 1.62 fold higher in 990 women with PCOS compared to 900 controls. And also leptin was higher in overweight than in lean women, and also in overweight women who had regular periods. Conversely, women with FHA have lower leptin levels than expected for their BMI, and it was around 40 to 60% lower than controls. And this analysis concluded that every increase of BMI by 1 kilogram per square meter is associated with an increase in leptin levels of 0.89, which is actually half of what we see in controls. Moving on to cortisol levels, this is we see changes that go in the same direction in both conditions. So cortisol levels are high in women with FHA compared to healthy women, and they normalize after recovery of menstrual cycles. And although their cortisol pulse frequency is unchanged, cortisol pulse amplitude is increased, and overall 24-hour cortisol levels are negatively correlated with the LH pulse frequency. And early morning cortisol values were higher in amenorrheic athletes than in ovulatory athletes or sedentary ovulatory women. And cortisol levels after a CRH stimulation test were lower in women with FHA than in healthy controls. Now, moving on to PCOS, cortisol levels are once again raised in this category, but their response to the CRH test is actually quite different. So ACTH and cortisol levels rise after a CRH test in women with PCOS. So whilst basal cortisol levels are elevated in both conditions and therefore wouldn't be helpful, a response to a CRH could differentially tell us if someone has more features of FHA or PCOS. And then very quickly looking at insulin-like peptide 3. So this is produced by ovarian thecal cells and the corpus luteum, and INSL3 levels are higher in women with PCOS compared to controls, but there wasn't any difference between overweight PCOS and controls. So the difference seems to only be in women who have PCOS but with lower BMIs. And they are only raised if these women have a menstrual disturbance phenotype of PCOS. But overall, INSL3 levels were found to have correlations with AFC, baseline LH, and also features of clinical hyperandrogenism. Now, due to the low gonadotrophins causing low theca cell stimulation at the level of the ovary, we would expect that INSL3 levels are low in FHA. So obviously, what we have been discussing so far very much suggests that there is so much overlap between these two conditions. So for example, if we take someone with FHA, so as a default, they will be amenorrheic. And if this woman then has an ultrasound scan and there's evidence of PCOM because of lots of follicles in the ovaries, she would by default then also be classified as PCOS. And indeed, there are a few different studies that show this overlap. So for example, of 159 women with FHA, 36% also met criteria for PCOS. And in another study of 122 women with FHA, 41 that were suspected of having underlying PCOS were found to have a higher LH, higher testosterone, and higher T-scores on DEXA scanning. But as you say, this is almost like a self-fulfilling prophecy, because how do you decide whether someone is high risk for PCOS if they have FHA? So for example, there was a paper saying women who had FHA and PCOM were found to later on develop oligomenorrhea when they put on weight. And indeed, we found two studies, that mentioned changes in the phenotype after either gonadotrophin stimulation in the context of IVF or after gaining weight and having for the purpose of treating their FHA. So 6 women with FHA and PCOM were found to have a higher risk of then becoming hyperandrogenic in the context of IVF. And also 5 of them who put on weight, they are found to become oligomenorrheic a few months later after the commencement of cycling. And 6 out of 120 women with FHA developed features of PCOS after pulsatile GnRH. But when we reviewed these papers, once again, they used very different criteria. So for example, one of the 6 patients, if I remember correctly, had a baseline LH of around 8 at the time when she was classified as FHA. And therefore, perhaps that initial categorization was incorrect. So overall, the features that were differentially altered between FHA and PCOS were GnRH pulsatility, BMI levels, levels of LH, androgens, insulin, AMH, SHBG, endometrial thickness, and cortisol responses to CRH. And other tests that might have potential but need to be explored further are those of 5-alpha reductase activity, the leptin levels, INSL3, and inhibin B levels. So thank you very much for your attention. I'm so sorry, I know it was a long and dry presentation, but I also wanted to say.
It wasn't dry at all. That was very interesting.
So
Thank you.
15 years ago, I had a patient with all of these, most of these, and I was struggling to see whether it was PCOS and or FHA. And I went to a professor sitting to my left, and he said it's all made up. I think at the end of it, we just confirm this suspicion.
Well, there's probably 4 categories of PCOS, but being
Yes.
so everybody kind of says increasing possibility in PCOS, but that's mainly the in. So we recruited, so I know I recruited some PCOS patients, and then looked at their basal genetic positivity. It was only about 6 from pilot study. So, and one of them was beautifully raised, positivity. The next one was a bit low.
Right.
So if they've got obesity, they'll have secondary hypertension.
The terminology isn't working.
Well, it's not a disease, it's heterogeneous, that's the problem. So it's a bit like a.
So you've got people who do.
Can I say diabetes? Never start coming down. We had type 1 and type 2, now
Yeah.
You've got people who do or don't have periods. You've got people who do or don't have features of personality. And obviously if they're thin and not, then I would default to the left. Obviously I'm being a bit binary.
Well, the primary bit is the extreme ends, isn't it? So if they're extremely thin, it's easy. Yeah, amenorrhea, looking very thin and have a history of eating disorder, they'll go left. Yeah.
So how about the aromatase story? So the excess adipose tissue in your obese PCOS, converting your androgens to estradiol and causing secondary hypergonadism. That's why they're called.
I think the problem we're going to find, right, is that in the obvious ones, all the tests are obvious, and in the ones in the middle, they're all going to be great because all of them are going to be slightly. Yeah. So is it the same condition?
No, it's a different condition, but I think within PCOS.
Yes.
So I mean, so that's the problem.
I think with the spectrum between well, it's going to be lots and lots of different genes all adding up to this.
So actually, there'll be groups within that whole massive spectrum. So if you're, and there's going to be overlap as well. So there'll be patients who have got FHA, and then have got Ovarian Morphology.
Yes, Maria, what's happened to your 21-year-old student?
Well, I was going to ask you, how would you categorize her?
You want to
Given.
Yeah, do we just
yes, for sure.
While you're doing that, if someone's obese and got a lot of estradiol, what's that doing to the Gnrh positivity LH? Should be suppressing it, shouldn't it?
Depends on how it is. That's why
So here, these are her blood results and ultrasound scan.
Yeah, so she's right in the middle, isn't she? BMI sort of 20, not the typical anorectic view.
But the BMI is not that helpful either because you've got an athlete like me who's athletic and muscular.
Yeah.
High BMI because of the muscle. It's not due to the fat. So
I mean, this patient is not doing lots of exercise. She sounds like a completely normal student. But that is
AMH is a little hard. It's a little towards PCOS.
yeah, it's on the high end. Yeah. See, if your AMH is on the high end, then the LH to FSH ratio doesn't fit. So
So the LH to FSH. Yeah. I was
about 40% of patients that have it.
but some of them,
yeah.
some of
So
them,
her LH.
yeah, sometimes it's 10 to 3.
She's not got estrogen.
Yes, she's got no estrogen.
So isn't that
Yeah,
isn't that functional hypothalamic amenorrhea?
By
No
Roscoe-
estrogen.
Okay, so Emma's voting for functional hypothalamic amenorrhea.
Well, I'm just saying, what no estrogen.
Yes, and then what are you going to do about it? You're going to say eat more food.
I don't know.
But by
Yes.
definition, PCOS,
So, but
Ovarian Morphology and AMH.
yeah, but she might be one of those women with FHA who happens to have a PCO morphology, or she might be someone who, when she puts on weight, she then develops PCOS because she has an increased intrafollicular count reflected by the high AMH and also the ultrasound findings. So we have sent insulin and C-peptide levels, which we are expecting, and we have done a pulsatility study that we're very keen to analyze, but we haven't analyzed that yet. So we agree. So we have also categorized her as FHA, and of course we think that perhaps that's where a kisspeptin test might be able to help us differentiate these women, because we're finding that women.
Tests.
Did you show any results for kisspeptin tests?
Yeah, I can find them. Sorry.
Adrenal androgens high in PCOS. What's driving the adrenal androgen synthesis?
It's a good question. And
So
then,
these are.
yeah, go on. I just would this then drive your therapy for this patient? If you call her FHA,
Sorry, I couldn't hear that.
sorry, if you call this FHA, will that? How will you manage it? Will you say, right, you need to put on some weight?
Exactly, and then you risk them becoming PCOS.
And obese. She's got a perfect BMI. And increase her risk of cardiovascular disease.
The other reason hypothalamic axis shuts down.
Yeah.
If you want to breathe
Because the
through
student is
this-
terrible.
Exactly.
Finals.
I mean, you know, I think they have to. Not
Can you hear Jeremy? Jeremy's got a question.
Go on.
I mean, it's pretty fantastic. A lot of data for our heads for some of us to take in. So the problem, for instance, on that case you have demonstrated, the question, the problem I have is I often end up investigating both ends of the axis, and so I end up doing an MRI of their pituitary. And so, for instance, in that case, would you have said, oh, well, I need an MRI of the pituitary here? Because a lot of the hypothalamic amenorrheics, you know, people come through various clinics, some of them you will then pick out, of course, do have a pituitary issue. And so the trouble for our investigation, Maria, is we do a bit of a scattergun approach. We actually fire investigations off at these people, do far too many investigations.
Yes, yes.
I look back at my patients and think, God, what was I so stupid? Why on earth did I do so much? And I feel a bit incompetent. So Maria, what we really, I mean, one question is, did you do an MRI on that lady? And question two would be, can you produce a sort of algorithm that would reduce our overzealous use of investigations in these patients? Because I sort of think that's a major issue for us. I end up doing GnRH tests, MRIs, and really it seems foolish to be doing those tests.
Yes, and I wholeheartedly agree with you that we tend to over-investigate these patients, and we end up doing tests that then don't actually tell us or help us discriminate these two conditions further. Like, for example, a GnRH test might perhaps only reflect the patient's baseline gonadotrophins on the day of having the test, so this is something that we are also grappling with. So, and we recruited this participant. She emailed us when she saw our flyers at the Imperial campus, and we will be referring her to the bone clinic. So you might be seeing her, or Dr. Condinos might be seeing her. She's 21. Sorry.
So one caveat to the PCOS guidelines is to be cautious about interpreting ultrasounds in patients, I think is within 8 years of the menarche, because they often have excess follicles as they're developing. I think it says 8 years, doesn't it, in the guidelines?
Yes, and also again,
about 13, she's still, you know, it's difficult. Yeah, and they're small ovaries, so it may just be early ovaries rather than actual PCOS. PCOM.
And in fact, I had a chat with the sonographer who's very kindly helping us with this study, who is an IVF sonographer. And I emailed her saying, we're not sure. So we are really looking forward to the results of her ultrasound. And she said, actually, I wasn't very sure either, because if you look at follicular number per ovary, she had more than 20 bilaterally. So she's PCOM. But if you look at her ovarian volume, which is less than 10, mils, then she doesn't qualify. Of course, the guidelines say either or, and so she called her PCOM in the end.